Welcome to this explainer. Today, we're unraveling what I think is a totally fascinating medical detective story. We're going to trace a path that starts with something incredibly common, unexplained brain fog, fatigue, maybe some memory slips, and we'll follow the clues all the way down to a completely different part of the body, your gastrointestinal tract. By connecting the dots between your brain, your blood, and your gut, we're going to look at some truly groundbreaking clinical guidelines that are changing exactly how we investigate these everyday symptoms. So let's get into it.
Okay, let's dive into this. Have you ever felt that persistent, heavy fog? The kind where you're just forgetful, mentally exhausted, and struggling to concentrate, but you just can't pinpoint why? Well, we often brush this off as just stress or, a lack of sleep. But what if your brain is quite literally starving for a vital nutrient? We're talking about iron. Iron is absolutely critical for transporting oxygen, producing brain chemicals, and generating energy. Without it, your cognitive engine simply stalls out.
To put into perspective just how sensitive your brain is to this, look at this alarming number, 150 milliseconds. Research shows that even if you don't have full-blown anemia, simply having low iron levels can cause your reaction times to drop by up to 150 milliseconds. I mean, think about that for a second. That kind of delay can seriously impair everyday tasks that require quick thinking, like driving your car on the highway. Your brain is literally lagging because it just doesn't have the fuel it needs.
And the sheer scale of this issue is massive. Iron deficiency is definitely not a rare condition. In the general population, about 5 to 10% of people are deficient. But look at the numbers for women of reproductive age. 15 to 20% are deficient. And for pregnant women, it jumps all the way to 25 to 30%. That means millions of people are walking around with this missing suspect, impacting their daily lives, often completely unaware that their cognitive struggles actually have a very physical, measurable cause.
So here is our roadmap for today's explainer. We'll cover the brain on low iron, diagnosing the iron shortage, the gastrointestinal investigation, suspects, celiac and H. pylori, and finally, treatment and next steps.
Section 1. The brain on low iron.
So, when your brain is deprived of iron, the cognitive hit is actually pretty severe. Studies show that adults with iron deficiency anemia see their memory and reasoning scores drop by 1 full standard deviation. Why is that? Well, because mitochondria, the powerhouses of your cells, they actually require iron to function. Specifically, iron is a key part of the electron transport chain that generates ATP, which is the brain's cellular energy. In a low iron state, ATP production just plunges. Your neurons literally do not have the energy to fire properly.
And this brilliantly illustrates exactly how iron impacts our mood and motivation too. See, iron acts as a crucial cofactor, basically a helper molecule in the brain's chemical factory. To make dopamine, your brain takes an amino acid called tyrosine and converts it to L-dopa, which then finally becomes dopamine. But that conversion process, it requires iron. If iron is low, dopamine synthesis slows right down. This is exactly why iron deficiency doesn't just cause brain fog. It absolutely kills your motivation and can even lead to anxiety and depressive symptoms.
Section 2. Diagnosing the iron shortage. So, how do we catch this? We do it by comparing 2 crucial blood metrics. Think of ferritin as your body's iron warehouse. It measures the iron stored inside your cells. Now compare that to TIBC, or total iron binding capacity. This measures your blood's capacity to transport iron via a protein called transferrin. Think of TIBC as a fleet of delivery trucks. If your warehouse is completely empty, your body essentially panics and sends out a massive fleet of empty delivery trucks desperately looking for iron to bind to. So low ferritin combined with high TIBC is the classic signature of iron deficiency anemia. Now, what's really interesting here is the strict new standards set by the American Gastroenterological Association, or AGA. They strongly recommend using a ferritin cutoff of 45 nanograms per milliliter to diagnose iron deficiency in anemic patients, rather than the much older lower cutoff of 15. Why make the change? Because choosing 45 maximizes diagnostic sensitivity up to 85%. They really want to catch the great majority of patients who are truly deficient, avoiding diagnostic delays so they don't miss serious underlying causes, like gastrointestinal cancer.
Section 3. The gastrointestinal investigation.
This is where things get serious. The AGA provides a very strong recommendation here. For asymptomatic postmenopausal women and men with iron deficiency anemia, they strongly recommend a bidirectional endoscopy. That means taking a good look at both the upper and lower GI tract. The evidence shows that for this specific demographic group, the underlying risk of a gastrointestinal malignancy is several-fold higher than in a standard screening population. So it's an absolutely vital step to rule out things like colon or stomach cancer.
But notice how the clinical algorithm kind of diverges here based on who the patient is. While older adults get a strong recommendation for an immediate endoscopy, the recommendation for premenopausal women is only conditional. Why the difference? Well, because premenopausal women have other very plausible, completely common reasons for iron loss, namely menstruation and pregnancy. The clinical guidelines treat these groups differently, basically requiring doctors to weigh the small risks of an invasive endoscopy against a much smaller risk of a GI malignancy in younger women.
And this highlights a really major theme in modern medicine: shared decision-making. The AGA suggests that some younger patients, when fully informed of the risks and benefits, might actually opt for an initial course of iron replacement therapy first, rather than jumping straight into an invasive endoscopy. It's really all about tailoring the investigation to the individual's specific risk profile and personal values.
Section 4. Suspects: celiac and H. pylori. When investigating hidden iron loss, two of the usual suspects are H. pylori infection, which can cause ulcers and decrease iron absorption, and celiac disease, which actually damages the small intestine. The AGA guidelines strongly favor smart, non-invasive testing for both of these. They suggest using breath or stool tests for H. pylori and a simple blood test, serology, for celiac disease. This approach is highly effective, it's cost-saving, and it saves the patient from having to undergo routine invasive small bowel biopsies right out of the gate. Interestingly enough, the AGA also advises against using routine gastric biopsies to diagnose autoimmune atrophic gastritis in these patients. The logic here is highly practical. Basically, even if you find it, there is no proven therapy for this specific condition, and it lacks clear management implications that would actually improve patient outcomes. So the guidelines focus the investigation strictly on actionable intelligence.
Section 5. Treatment and next steps.
So the crucial point is, if the standard bidirectional endoscopy comes back completely clean, what do you do next? The AGA suggests starting a trial of oral iron supplementation first, rather than instantly escalating to a high-tech video capsule endoscopy to search the small bowel. Often, simply replenishing the iron effectively resolves the anemia without needing any further invasive tests. However, there is a major clinical exception to this rule. If the patient has comorbid conditions, specifically if they're on blood thinners like anticoagulation therapy, then a hidden bleed is just way too dangerous to ignore. In those specific high-risk cases, deploying the video capsule endoscopy becomes a completely necessary step to ensure there isn't some life-threatening lesion lurking in the small bowel.
Let's move to and see how this builds perfectly into an overarching theme of modern clinical care: patient empowerment. The guidelines explicitly state that patients who place a high value on avoiding the small risk of endoscopy and a low value on the very small risk of missing a gastrointestinal malignancy would reasonably select an initial course of iron replacement therapy. It's really about putting the patient in the driver's seat.
Which brings us to the end of our explainer today and leaves us with one pretty provocative question. Is your unexplained brain fog actually a plea for a gastrointestinal investigation? We've seen how a starved brain, absolutely desperate for dopamine and energy, is so often at the mercy of a leaky or malfunctioning gut. Armed with this knowledge, you are now empowered to connect your neurological symptoms to systemic clinical science. So talk to your doctor, ask about your ferritin levels, and whatever you do, don't let the suspect get away. Thanks for exploring with us.